is the delay. Good afternoon. Welcome to Samaritans Purse International Health Forum, and thank you for joining us. I am Tom Boovey. I'm sitting in for Lance Plyler today as your host. We hope you all participate in the conversation today. You can chat with us in the chat box inside the video. Before we begin, let's begin with a word of prayer. Dear Lord, thank you for this day. Thank you for this opportunity to come together for this forum. Thank you for Cindy and Jason and this opportunity to learn about the orthopedic surgical subspecialty team. What a blessing we have today to present them to you and for this opportunity. Bless us, forgive our sins. In Jesus' name, amen. Well, today I have the pleasure of introducing a couple of my favorite folks, Dr. Jason Fader and Cindy Albertson. They're going to talk about surgical subspecialty teams, in particular our orthopedic team. Dr. Fader is a good friend of mine, grew up as a missionary kid in Kenya, where his parents worked as full-time missionaries at Kajabi Hospital. Now I have to pause a little bit and make a big deal about his training at Calvin College. I did bring a little something for you, Jason, there. He also went to Loyola Medical School and completed a surgical residency and fellowship in Ann Arbor at St. Joseph Mercy Hospital. He's married, 3 beautiful daughters, lives in Burundi, and works as a surgeon there, keeping very, very busy at Kibuye Hospital for the past 6 years. Cindy Albertson joined us here at World Medical Mission a year ago. She's a registered nurse, been in clinical practice for 12, 15 years now. She completed her master's degree in public health with a focus on global health. She's been involved with medical missions for 15 plus years, including international short-term teams, leading these, serving in West Africa, Ebola response and recovery efforts, as well as serving with Samaritan's Purse disaster response team in Iraq and Bangladesh. Cindy currently serves as World Medical Mission as the surgery subspecialty team program manager. Cindy, thank you for joining us.
Hi, this is Jason. I'm coming in from Burundi, so I just wanted to say hi and welcome to everyone out there. It's a great opportunity to share what what Samaritan's Purse has done here at Kibuye through these subspecialty teams. I will now hand it over to Cindy, and she's going to do the first part of the PowerPoint, and then I'll pick up when she's done.
Well, good afternoon, everyone. I'm excited to be here with Tom and as well as with Jason for this presentation. If we can go ahead and move on to the next slide. First off, just want to review our objectives. We're going to review the global surgical and sub-surgical situation, recognize when and where a surgical subspecialty approach would be appropriate, and understand the advantages and disadvantages associated with surgical subspecialty campaigns, especially in low to middle income countries. Next. Sorry, I'm not seeing the slides advanced, so. Are they advancing? Our first technical problem. There we go. All right. And we can go ahead and move on to the next slide. All right. So as we get started on this presentation, there were two terms that I wanted us to just quickly review. The first one is DALYs, which is Disability Adjusted Life Years. And this is a measurement that deals with the years lost due to illness or premature death. The second one is the total dependency ratio. And this is a measurement of the economy and the pressure on the working class, which is persons age 14 to 65 within a country that support the dependent population. I've got a comparison there at the bottom of the screen comparing the United States' total dependency rate to Burundi's. And this correlates to 48.8% of the United States' population supports the economy and are considered the working class, versus Burundi, which is 10.4%. And these facts will be kind of pertinent and relevant as we get into the presentation and start talking about orthopedics and surgical needs globally, and more especially in Burundi. Next. Okay. Okay, there we go. Surgical conditions account for 26% of the global burden of disease, with surgeries in low to middle income countries accounting for only 6% of all surgeries. In 2010, it's estimated that 32.9% of all deaths globally were related to conditions requiring surgical care. That accounts for more deaths than HIV/AIDS, malaria, and tuberculosis combined. 9 out of 10 people in low to middle income countries lack access to surgical care, while disability and death due to surgical conditions in these countries continue to increase at staggering rates. These countries are plagued with immense surgical staffing deficits, few if any specialty surgeons, as well as stagnant or degenerating surgical and anesthesia services. Sub-Saharan Africa and Southeast Asia have the greatest unmet surgical need and thus the highest incidence of avertible death and disability. Annually, 77.2 million disability adjusted life years, or DALYs, could be averted through access to even basic surgical care. Next. When we're talking about injuries and orthopedic incidents globally, 77% of all preventable deaths are due to injuries, with 90% of these deaths occurring in low to middle income countries. Injuries are the leading cause of death for persons aged 15 to 29 years of age. And this kind of goes back to the total dependency ratio. This is a good portion of the working class. This trend is predicted to continue to increase exponentially, further hindering economic sustainability and growth in low to middle income countries. Daily within these countries, 30,000 to 50,000 persons are permanently disabled due to musculoskeletal injuries and lack of orthopedic surgical care. Sub-Saharan Africa, that region in particular, has the highest incidence of DALYs due to orthopedic injuries and has one of the lowest number of orthopedic surgeons per capita. With the current hip fracture mortality rate of 20% within low to middle income countries, if that trend continues to grow as expected, economic and societal impact within these countries will be unsustainable by 2050. Next. Samaritans first became engaged in surgical subspecialty for the first time back in 1997 with the Children's Heart Program. This program focuses on 4 congenital heart conditions, and children are brought from various countries for surgery. In 2011, the cleft lip program was started, and that was based on a needs assessment done in South Sudan. And then in 2017, the cataract program was added. And that was birthed out of the needs for Liberia Ebola survivors. Locations for these campaigns are needs-based. World Medical Mission, as Tom had mentioned, started the Surgery Subspecialty Teams program back in 2018, with our campaign started in 2019. The surgical areas of focus are orthopedic, most specifically the appendicular skeleton, hydrocephalus, obstetric fistulas, and these campaigns are done at partner mission hospitals. Next. Campaigns at our partner mission hospitals complement the hospital's long-term and local surgical efforts to meet an otherwise unmet surgical need. This is accomplished through the sharing of knowledge and skills, provision of equipment, and establishing a collegial network between the volunteer surgeon and the surgeons serving on the field. Next. We went too far. We missed one. Slide 8. There we go. There's a myriad of factors that impede the provision and access of basic health care and surgical care in low to middle income countries. Broken healthcare systems, whether that's locally, regionally, or nationally, including scarce resources and poor infrastructure. Additionally, due to necessity and scarce resources, the focus on surgical care is typically on acute emergent needs, with up to 80% of these surgeries being completed by associate clinicians with little or no formal surgical training. The impact of unmet surgical needs has a direct correlation to increased mortality and morbidity for these populations. So with a surgical subspecialty campaign, the surgery is elective and non-emergent. It's safer for the patient and allows the local surgeon to gain needed skills and knowledge. It allows for a planned, reproducible approach that is very impactful on reducing long-term morbidity and mortality. Not only is there a transfer of skills to the surgeons on the field, but the donated equipment and collegial network provide support and growth for the specific surgical procedure onward for the mission hospital. Safe, effective surgery is the power to transform lives and an effective means for sharing the hope of the Savior. And at this time, I'm going to turn it over to Jason.
Great, next slide. So before Samaritan's Purse World Medical Mission came to Kibuye to do this campaign, we talked a lot about what the objectives are. And so there were a lot of emails that went back and forth, and we decided on these. The first objective was to demonstrate the love of Jesus Christ through the provision of surgical care and high quality surgical care, providing both physical and spiritual healing. So, the difference between any typical hospital and a mission hospital is often that there's a spiritual component there. And so we really wanted to engage our chaplains in this and make it a spiritual and physical healing time. We decided to aim to complete about 20 or 25 complex orthopedic surgeries, which are not presently available at Kibuye. That may seem like a small number. The team was here for a week, and I think that there's a temptation in a campaign to really push and stay up till 10 and 11, 12 at night and be in the OR and see how many cases we can do. But we intentionally it ended up being 28 cases, so we didn't follow what we had planned to do, but we wanted to keep it at a relatively low number so that we could complete the objectives below. So the third objective is to increase the expertise of the Kibuye surgical staff through skill transfer. So this transfer of skill cannot be done if the team and if the hospital personnel are strung out and are working from 7 a.m. to midnight. And so we wanted to keep the cases to a minimum, to a relative minimum, with the idea that if we could do a good skills transfer, that then we could continue the work that was started by this surgical team coming. We also wanted to have time to establish a collegial relationship between volunteers and the Kibuye staff so that there would be an ongoing knowledge sharing and networking. And that happened, and it's a great benefit of having the team come. And then lastly, World Medical Mission graciously provided biomedical support for Kibuye during that time and beyond in terms of equipment evaluation, service, and repair. So these things, surgery is not a bubble. There are so many things that have to happen in order for the operations to go without a hitch and to be done well, including working anesthesia machines, working Bovie machines, oxygen, light, all of those. So we were very happy with the biomedical support that came along with the team. Next slide, please. So the volunteer team, you see them there, standing outside the surgery ward. This included a full-time Dr. Dan Gallett, who's at Kajabi Hospital in Kenya. And he brought along with him a PACS resident, Dr. Jomo, who's in his 4th year. And Dr. Jomo, I don't think had been to Francophone Africa before. And so this was kind of a mission trip for him as well. And he had a lot to teach us, and that was great. There was an OR scrub nurse, a PACU nurse, and then a CRNA as well. And each of those nurses did a wonderful job of doing skills transfer as well. It wasn't just from surgeon to surgeon, but it was from anesthetist to anesthetist and from nurse to nurse. And then there were 2 biomeds that came, and they were a huge help. And then there was Cindy that came, and Lance came along too. So it was a great team. And we were so thankful to have them and to receive them here at the hospital. Next slide. So how did it go? What went down? So it started long before that week that the team came, and it started with patient selection. And so what we did here at Kibuye is that we sent out a number of radio announcements, which was a very effective means of communicating that there was a specialist orthopedic team coming, and we were inundated with patients. And so there were many weeks and months before the campaign started where our clinic volume was doubled or more with all the patients that needed to be triaged. And so then what we did with those patients we would select some that we think were appropriate, and then we'd take pictures of x-rays and send them to Dr. Gallett and Dr. Jomo and ask, is this something that you think is feasible and is that we want to do during this week, one of the 20 to 25 cases. And then so we started making a list of patients that we wanted to do and that we thought were feasible. That created an equipment list, which was generously donated by World Medical Mission. So orthopedics is a subspecialty that needs a lot of equipment, screws and plates and nails and external fixators. And so we made a list of the consumables and supplies that we needed based on the selection of patients. And then internally, among the surgeons here at Kibuye, we looked at that list and we thought, so for example, if there's 8 hemiarthroplasties of a hip that we want to do, if each of us does a couple of them, then probably we'll know not just enough to be dangerous. And so what we decided is to, among the surgeons, to divide up the types of cases so that one surgeon could do a lot of the hips and one could do a lot of other types of surgeries. And that way, after the team leaves, then among ourselves now, we have we have taught each other, we've scrubbed with each other to spread the wealth and to teach each other how to do these cases. And so it was a double skills transfer in that sense. And then, as I mentioned before, the chaplaincy program here was contacted and engaged, and it was a great opportunity because patients that would not normally have come to the hospital, because we did a nationwide radio announcement, there were a lot of people that came in from different parts of the country and outside the country, and we were able to engage them in a spiritual way as well. And so that went very well. Next slide. So what are the campaign outcomes? And in one sense, I would want to skip this slide. As I mentioned before, I think a lot of emphasis is put on what happens during the campaign. And I think something that went very well this time is that the World Medical Mission was agreed to kind of hold back and say that we're not only focused on what happens that week, but we are focused on what this week will enable the hospital to do in the future. And so it was a very successful week, but it was also a very successful many successful months that followed because of that week. So during that week, it was busy enough. We had 28 patients that got orthopedic surgery. About half were, just 64% were male and 36 female. People from all ages, young kids that had congenital deformities, all the way up to older folks that had fallen and needed help. The types of procedures that we did mostly were internal open reduction internal fixation, so ORIF. So these are plates and screws and nails, and many of these were chronic injuries, so patients who had fallen years ago or who had been through many operations and still were not able to walk, or had chronic pain that came and needed help. Here at Kibuye, we had the capacity to do basic ORIF, and so we made the conscious effort to not bring in cases that we could do already, but the cases that would push us as a surgical team to expand our horizons. And so these cases were certainly complicated, and the surgeons that came and the team that came were amazing in helping us with that. 18% of our cases were hemiarthroplasties of the hip. So this is a procedure, you know, when someone breaks their hip, there's not a lot of options outside of hemiarthroplasty, especially if you don't have a C-arm to do what's called a DHS. So we wanted to, there's only one or two other surgeons in Burundi. That's a country of 11 million people. So that's like all of the Chicagoland area, or Indiana and Kentucky all combined. There's two surgeons that do hemiarthroplasties of the hip. So there's a tremendous need for this procedure. And so one of our main objectives was to get above the curve on this and to really learn how to do these well. And so one of our surgeons really concentrated on this, and so we did a number of those hip hemiarthroplasties, a couple of external fixators, and that's kind of a basic procedure, but there are a lot of little tips. And in the picture to the right there, you can see Dr. Jomo teaching one of our local surgeons, Dr. John, how they're doing an X-Fix together. And Dr. Jomo, he had all kinds of, like I've done 50 of them, but when he came in, he's like, oh, but if you do this and this and that, it was great. He had so much to teach, and we're thankful for that. So even simple things, there's a lot of tricks of the trade that we can learn. Dr. John, the other side, he's actually a Samaritan's post-resident. He's here for 2 years, and he's a general surgeon like all of us here. So none of us are trained in orthopedics. And so it's really nice to have an ortho team. We did a couple osteotomies and then a couple of miscellaneous cases as well. But overall 28 cases. Next slide, please. What are the advantages and the ideals and the challenges of the short-term team approach? There are plenty of all of those. So the advantages, we can start there, is that there's a full integration within the mission hospital focused on increasing the capacity of the hospital to meet an unmet need within the catchment area. So in talking beforehand with the World Medical Med team, we talked about, what is the need? We do hydrocephalus already, and so we thought that team wouldn't necessarily be needed here. We do cataracts already, so we wouldn't need that team here, but there is a lot of orthopedics. And as Cindy alluded to in the talk about public health in the beginning, this is a society where if you can't walk, it's really tough to live. There is no ADA, there's no wheelchair accessibility almost anywhere here. And the terrain is mountainous, and everybody, 90% of the population are farmers. And so if you can't walk and really get around, it makes for a very difficult life. And so orthopedics was a huge need, and especially a little bit more advanced orthopedics than what we were able to offer. So having a team come in that's very experienced to help us rise to that occasion is huge. Another advantage is that it allows for a platform from which to build another skill. So as I mentioned, we did a number of hip hemiarthroplasties, and now we're doing a lot on our own. We do about 2 a month since the team left, and all of the surgeons here are now capable of doing them well and independently. And in fact, we're outstripping our supply of material. So we're having to order more, and it's a great problem. And so the next step beyond hemiarthroplasty is to replace the whole hip, the acetabulum and the femoral head. And so that would be an example of, now that we've mastered kind of this hemi hip, then maybe a next step would be to get a team back and do a total hip campaign. And then after that, boy, I hope we can hire our orthopedic surgeon, because these are starting to be quite difficult operations for a general surgeon. Another advantage of having a short-term team come to a hospital that is providing care is that when the team leaves, that hospital can continue to give care. Thankfully, we didn't have any complications with the patients that we operated on. But if there were complications, then it would be important for them to be able to come back and meet with a surgeon who was involved in the operation so that they could deal with the complication. And this goes back to, or goes on to the next point, where there's a collegial relationship and networks. So, now that this team has been here, me as a surgeon, I send Dr. Gallant emails all the time with x-rays and say, hey, do you know what we could do in this case? And instead of suggesting something that's not possible here, like instead of saying, well, yeah, get an MRI and then use a C-arm and put in a DHS, he knows that's not possible. He's been here, we've worked together, he knows my capacity. And so now with these relationships formed and the team having been here, we can continue to care for the patients that are around us. And then one of the other advantages is that it allows for a planned and a reproducible approach. And that's the idea behind even this webinar, is to say what went well, what didn't go well, what can we do better next time, and to create an approach that works in other contexts as well. We can learn from each other, and then and provide better care around the world and increase people's surgical teams' capacities around the world in a whole variety of different mission hospitals. Next slide, please. So what are some of the ideals in a subspecialty team? One of the ideals is that surgery is elective or aesthetic, such as cleft lips, and cleft lips more than cleft palates, and also non-emergent. So this helps with planning. These things, a team coming out to Burundi or anywhere does not happen overnight. And so there's a lot of planning ahead. And so it helps if the cases are elective or semi-elective, and that a schedule can be made so that an equipment list can be made, so that we can see, what exactly we need to meet the needs of these operations. Another ideal characteristic is that it meets an otherwise unmet specialized surgical need. So there are times when, having another general surgeon come out here and work alongside the general surgery team is great. And certainly there are enough patients to go around. There's plenty of work to do. But one of the ideals of a subspecialty team coming out short term is to meet a need that's not met, and then to transfer that skill to the team that's on the ground. So that's the next point, and something that this team did so well. In the picture on the right, you see the CRNA with our local anesthetist. And so there was cross-pollination there among anesthesia. There was a PACU nurse, and that was always, taking care of the post-op patients. And, that's another thing where the next point is good for the hospital. What happened there is that when the team came and had a post-op nurse, we started for the first time at Kibuye a recovery room service. And so now, since the team has left, we use that week as a jumping point, and we created a recovery room paper that, fill out the vitals and follow the patient, and what are the criteria for the patient leaving the recovery room. All of that happened the week that Samaritan's first was here, and it has continued on. And so that's another example of a great skills transfer between nurses that has greatly increased our quality of care here at Kibuye Hospital. Another type of skill that was transferred was from the biomeds. So that it was great to have them here, and we have a couple of we have an engineer on site, a couple of technicians on site that worked with Todd and Bert to fix. We have like a graveyard of broken machines, and so Todd and Bert and Caleb and Dieudonné and Vianney, they tore through those and got them working again. Except there were some that needed a part, and so in fact, so Todd made a list of all the little parts that he needs to fix various instruments and machines, and he came back 6 weeks later, having acquired all of these little capacitors and whatever he needed. And that was World Med again that supported him in coming back and completing the fixing of so many machines. And so that was a huge asset. Opening a recovery room that week that they were there, we needed more monitors, and a lot of our monitors were broken, but man, Todd and Bert, they whipped them together, and we were able to provide much higher quality care because of their presence. And now we continue, Dieudonné, Vianney, Caleb, now they are capable to repair things, and they too are in contact with Todd, and they can say, hey, this monitor, you put this in, and now we need this. And Todd knows, again, what our capacity is. He's not going to tell, Caleb to run to the Radio Shack down the road. He knows that, we have limited capacity here, and he's been here and he knows. So it's a great skill transfer across all levels. And then World Med was very generous to leave so much equipment with us, a small fragment set, a large fragment set, and now we continue to use those on a regular basis with the newfound skills and newfound equipment based on this week that Samaritan's first spent here. Next slide. So challenges. So we learned some things during this week, and we'd like to share those with you with the idea of of creating better teams in the future. So one of the challenges was that the surgical subspecialty team is restricted by the capacity of the mission hospital. So that's true anywhere a subspecialty team would go. Generally, specialists or subspecialists are restricted to a bigger hospital, a more well-equipped hospital that have higher capacities. But what's important is the team that comes needs to be flexible. They need to see what our situation is, and then they can work within that capacity at the mission hospital. Surgeons who are willing to champion and take responsibility for that surgical subspecialty maintenance and growth. So that's us on the ground. As mentioned before, it involves a lot of work beforehand, a lot of work during the week and after. But in the end, if there's someone that has the capacity to and the willingness to champion that, it works great. And again, I think dividing up the tasks or dividing up the objectives is really helpful, and so that we can ensure that there's a champion in each corner. So maintenance of durable equipment beyond the campaign, and this is related to that skills transfer, and things fall apart. That's just the reality of how things are, and so being able to fix the complex equipment or the complex machines that were left behind is very important. And I think that World Med did a very good job of bringing two biomeds, and those two guys were very helpful in transferring those skills. And then another challenge is the availability of appropriate consumables beyond the campaign. So this takes a little bit of talking back and forth. So for example, for doing hip hemiarthroplasties, you need cement, and cement we can't get it in the country. And so we need to find out a way to get the cement either in India or Kenya. And so it's just something you need to think about. If you're going to have a short-term team come and do a specific skill transfer, or an increase of your capacity, make sure that it's something that you can, continue on after the team leaves. Another challenge is the volunteer surgeon who comes. To no fault of their own, a lot of surgeons who work in plentiful situations are used to having CT scans and MRI scans and C-arms and a whole variety of plates and screws and screwdrivers and drills and batteries and all of this. And so it's important to choose those people well. And Dan Gallant and Dr. Jomo were perfect fits for this environment. Kajabi is certainly a couple of notches above where we are in terms of orthopedic capacity, but due to their flexibility and due to their ingenuity, both Dr. Gallant and Dr. Jomo were able to really do well here at Kibuye and help us discover ways that we can provide better orthopedic care in our austere environment. But that's not to say that someone working in a first world situation shouldn't go on these trips. It's just, it's important to have that in mind, that you're not going to have, the bone clamp that you're used to having all the time, or you're not going to have maybe the type of suture that you've always used. And so it's just important to be flexible. The other challenge is the time commitment. There's no doubt there's a lot of time put into this week, a lot beforehand, triaging, all of those patients that thought this is their chance to get, their orthopedic procedure they need. It seemed like everybody in their family was coming to be triaged. So there's a lot of time commitment beforehand, and also after. There's a lot of follow-up that should happen after these campaigns, not only for the patients, but SP appropriately brought a media team along with them, and there are stories that should be told, and finding those stories takes time. but it should be done. And so again, it's not a critique. It's just something that to be aware of. It's not just 1 week out of the schedule for the hospital. It's a time commitment on both sides of that. But in this case, it was well worth it. And we are so thankful that the team came. Next slide, please. So some of the lessons that we learned, we've been over a couple of these, but the first is that focus campaigns work better than broader ones. So this again is something that we learned on this trip. This was an orthopedic campaign. And so the radio announcement was, hey, if you have a problem with one of your bones, come to Kibuye and we might be able to help you. And that's pretty broad. So everybody that has a problem with one of their bones came to Kibuye. And as it turned out, we limited ourselves to 20 or 25 cases. And that's not a lot when you're talking about a country of 11 million people. I think in the future, what would be helpful is to say, we're going to do non-unions, or we're going to do, total hip replacements, or a disease specific, or a little bit of a more specified disease that will be taken care of. That helps tremendously for patients not to have false hope. There were many patients that came and we said, oof, we just we can't do it. We don't have the capacity. And so that hurts when they had their expectations raised and then they have to be let down. If we could, on the other hand, say, hey, if you have a problem with your hip, come here and that's what we're going to take care of, then that helps triage better. The skills transfer, we've been through that, went great. As I said at the beginning, a lot of times short-term teams, it's a lot of energy and a lot of excitement. We're going to go and do, 1,000 whatever. And it's important for the team, as this team did, to think about what happens the week after you leave, and what new skills will be there in any number of domains that can be left and that can continue on. And man, I can tell you that these last 10 months since the team has come, we've been doing a lot of complex orthopedic procedures, and it's because of the things that we've been taught on every level. Another good example of the skills transfer is between Ali, the scrub nurse, and one of our nurses, Ajid. Ali is a scrub nurse, just as you would imagine, very precise, perfectionistic, and it is exactly the type of person that you want in the operating room. She knew where every instrument was and how to hand it to you, everything. It was great. And that was something that our scrub nurses had never seen before. They didn't even imagine that a level of perfection that like Ali brought could be there. And so it was just good to open their eyes to see, there's another level here. And the nursing care, the OR nursing care has improved drastically as well because of Ali and the great perfectionistic, OR nurse attitude that she brought. There were great relationships built on every level. And again, leave time for that, evenings to eat dinner together, lunches to talk together. That's very important, and it provides a longer lasting effect than just 1 week. So that involves an achievable schedule. And then the on-the-ground team, as we've talked about, needs to have time before and after for triage and follow-up. And all of that, I feel, went well, and we're very thankful for it. Next slide, please. So just to wrap up, just a couple of do this. Why, from a Christian perspective or from a biblical perspective, what is it that motivates a team to come out and help at a mission hospital? Certainly, there's the verse from Isaiah about there's the need out there, and God says, "Who will send?" And Isaiah says, "Well, hey, here I am." send me. And so we're thankful for the volunteering of this team to come out and assist us at Kibuye Hope Hospital. There's the aspect of the body of Christ. Boy, as a surgeon, I really feel this. You know, we as surgeons are really left out to dry if we don't have a team around us. We need someone to put the patient to sleep for us, someone to scrub the patient for us, someone to recover the patient for us, someone to sterilize the instruments for us, someone to mop up all the mess that we made in the operating room. Without that body, we are hung out to dry, and surgeons exemplify that tremendously. And this team, it was great. Everyone worked together, investing in the team rather than in self. And there was a very selfless demeanor about the entire team. Certainly, God calls us to heal and to heal those who might be an outcast. And as I said, people in this society, if they're not a social outcast, they're an economic outcast. If they're crippled, if you can't make a living, it's a very difficult life. And so having an orthopedic team come and enabling people to walk again who maybe have not walked in years, that's a tremendous outcome. And again, not only do we do this for these patients, but in the end, it's for Jesus. Our motivation, the motivation of the team that came and the hospital here is that, you know, we see Jesus before us, and so we want to treat our patients as if they were Jesus before us. Next slide. Here are some references for those who are interested. In the next slide. Voila. So this is what part of what it's about. This was at the end of a long day. Samuel and Casey hanging out, talking, comparing worldviews. What's your life like? Great interactions. So thank you. Thank you for the team. Thank you to World Medical Mission for bringing this team out here. It was a huge benefit and an ongoing benefit. And we are grateful. So that's all the slides we have. If there are people that have joined us that have questions, we'd be happy now to entertain any questions that you might have. Yeah.
Well, thank you so much, Cindy and Jason. I don't see any questions yet. I know I have a few. Jason, do you see any other possible surgical subspecialty needs that would benefit your facility?
Yeah, there is not a surgical subspecialty need that could not benefit our hospital. I'll say that. It ends up being the logistics and the capacity. As I mentioned earlier, you know, I was in clinic yesterday. I booked a patient for December. We're going to do he paid money, and we're going to do his hernia repair in December because we are booked all the way through. So it's a matter of capacity. You know, we're in a country here. Burundi has 11 million people, and there are about 25 surgeons. So this is the most impoverished surgical nation in the world here in Burundi. And so we could use any of it, any type of surgical subspecialty team. The question is how to integrate it. We are inundated with stuff that thankfully we can do. And even we've increased our capacity of what we can offer here because of this subspecialty team. And so what we need is more capacity, I would say. But there are certainly any number of teams that we could welcome here.
Great, thank you. Here's a question, probably for Cindy. How do you determine who will make up the team?
Well, as Jason talked about earlier, there was a lot of discussion and a lot of planning that went into just defining the scope of the campaign as far as orthopedics and what the focus would be. Part of those discussions are also centered on what the dynamic of the team needs to be. What are the areas where we can bring volunteers who can speak into and add to the skills that are needed there at the hospital to go forward. We don't want to come in with a team that overshadows or displaces any of the staff at the hospital. We want our staff to come alongside and be integrated into their existing processes. So every team may look a little bit different. There has been one team that we had this year that did not have any anesthesia support because that was not needed from the hospital. So the team dynamics vary. It just really depends on the hospital and depends on the scope of the work that we're doing.
Yeah, I would add to that there are some traveling in Africa and logistics in Africa can be tough. And there was a delay. Dan Gallett wasn't able to come. He was delayed for a day due to some visa issues. And so it'd be helpful to have at least 2 surgeons on a team, on most teams, I would say, in order to mitigate those problems. So Dr. Jomo, he's Kenyan, so he doesn't need a Burundian visa. So he came on the plane and just started operating right away. So need to think about kind of replacements or having some extras if possible.
Very good. Well, thank you again very much. Remember, for all those listening, that CME credit remains available for this session. The form and the instructions are in your email, and we'll be sending follow-up emails and a link to this recording. If you're not on the email list, you can join the forum at health.samaritanspurse.org, and you'll be the first to know about upcoming events. Again, I want to thank Jason and Cindy for everything they brought with this informative session. Our next webinar will be Wednesday, February 11th. Barry Jessen, our Samaritan's First Country Director in Cambodia, will join us, talk about what's going on there. So thank you again for tuning in. Thank you for our guests today. And we will wrap it up there. Thanks.